This is completely a separate category. Till now, what I find the evidences, the benefits are there in heart failure with reduced ejection fraction. So let us see what are the evidences, what are the trials, what it shows in patients with heart failure with reserved ejection fraction. As we all know, out of all patients with heart failure, 50% are patients with reserved ejection fraction and 50% are heart failure with reduced ejection fraction. So if you do not address the issue of reserved ejection fraction, we are just ignoring 50% of patients with heart failure. This is a very informative slide where you see the difference is in patients. This is a patient of heart failure with reserved ejection fraction. They are obese. There may be involvement of the cardiac, pulmonary, liver, renal, visceral adiposity, musculoskeletal system in different ways. And there will be metabolic stress. So the metabolic stress, the aging, cardiac remodeling, ventricular vascular stiffening, sedentary time and again we are discussing because the risk of serious angioedema, more often in blacks, which is more often in blacks. Early scaling is a direct renin inhibitor. Here we should not do potassium sparing diuretics. We should be careful. This may lead to increased hyperkalemia, especially renal impairment, diabetes, and hyperaldosteronism. NSAIDs may lead to increase in risk of renal impairment. Lithium increase to lithium toxicity. Birth control pill containing droxiprelon has been found to be not very safe. What percent of patients with heart failure reduced ejection fraction and reserved ejection fraction will have contraindication to use of ARNI in real world? In the real world data, how many percent of patients with reduced ejection fraction and presumed will have contraindication? How do we manage hyperkalemia with ARNI insufficiency? So very important, because if you see in the real world, around less than 10% of the patients heart failure will have contraindication to use of ARNI. And in certain situations we will have to be careful by starting as conditions were mentioned. And if there is hyperkalemia, hyperpotassium, how to manage? Strict low potassium diet, small dose of loop diuretic that take out the potassium, potassium binding in emergency situation, potassium binding sachets, and combined aspirin nebulization. Nebulization can reduce the potassium. The old is gold, glucose insulin infusion in stubborn cases. So actually glucose insulin infusion make the potassium intracellular. From the extracellular we go to the intracellular. And this patiromer is a boon. Patiromer is a drug which can reduce potassium. Now scientists and physicians are contemplating in situations where we are using ARNI and MRA. If we use patiromer, the chances of hyperkalemia will be much less, and patient will get the benefit of both ARNI and MRA if patiromer can use in such situations. Consensus number 14. What would be the impact on lives of patient in case of discontinuation of ARNI? Whether ARNI should be discontinued. What are the situations? If the patient is intolerant to ARNI, then it will have to discontinue. If the patient develops or hypotension not coming up, definitely will reduce the dose, or if required, it may be discontinued. Other situation comes, ejection fraction improves. Patient improve from heart failure reduced ejection fraction to mid-range or preserved ejection fraction. Then what to do? That will be $1 million question. Let us see what the evidence says. To sacubitril valsartan in daily clinical practice data from prospective study, ARNI withdrawal in patients with heart failure and reduced ejection fraction were independently associated with increased alcohol mortality. If you withdraw ARNI, the chances of deterioration and chances of bad effect is there. So patients who continue with sacubitril valsartan presented an important improvement in functional class LVEF and NT-proBNP level. And this should ARNI be discontinued once LVEF improve, what I was telling, the so-called heart failure with recovered ejection fraction or heart failure with improved ejection fraction subset. You see, this is very informative slide. In patients heart failure preserved ejection fraction, 60 to 90% remain in preserved ejection fraction. 10 to 20% either go to heart failure mid-range ejection fraction or less than 10% go to heart failure reduced gradually deteriorate. With mid-range ejection fraction, mostly they stay in mid-range ejection fraction, but 20 to 30% go to preserved ejection fraction, further improvement, and 10 to 20% can also deteriorate to reduced ejection fraction. In patients who have a reduced ejection fraction, 60 to 80% remain in reduced ejection. However, these 20 to 30% what remain, they can improve to mid-range or improve to preserved ejection fraction. Here mid-range is 40 to 50, preserved is CF more than 50, and reduced is less than 40. If the ejection fraction improves, the improved ejection, recovered ejection fraction, whether are going to continue ARNI or not, what the guideline says. Guideline says in patients with heart failure improved ejection fraction, after treatment, GDMT should be continued to prevent relapse of heart failure and left ventricular dysfunction, even in patients who may become asymptomatic. Even if the EF improve, even if there is a patient is asymptomatic, we should continue ARNI. Otherwise, there may be chances that there may be development of relapse of heart failure and there may be LV dysfunction. So after this, we will come what are the pearls of consensus. These two slides are very important. You must concentrate these two slides. ARNI is molecule of century and is indispensable and superior to ACE inhibitor in reducing the cardiovascular death,